Hi everyone, good afternoon. My name's Stockley and I'm the Program Manager with the Vision Initiative. I'd like to begin today's session by acknowledging the traditional owners of the land that we're meeting on. In Melbourne, we recognise the continuing connection of the Wurundjeri people and the Boon Wurrung people of the Kulin Nation. I'd like to acknowledge the traditional owners of the lands you are all living, working and learning on today. And I'd pay my respects to elders past and present and acknowledge emerging leaders. I'd like to recognise their continuing connection to land, waters and community sovereignty over which has never been ceded. I would be grateful if you could all introduce yourselves in the chat and let us know where you are joining us from. Let us know the name of your workplace, and if you know, let us know the name of the traditional owners where you are. Joining me today are my Vision Initiative colleagues, Casey Levy and Melissa Morris. And I'd also like to thank Sabine Ostrowski and the Macular Disease Foundation of Australia for working with us to bring you this webinar today. This is the third in a series of webinars on the main eye conditions that cause blindness, and we wouldn't be here without the support and collaboration of Sabine and the MDFA. I'm going to move on to the tech housekeeping issues now. I think we're all well familiar with the way Zoom webinars work. Your cameras and mics are off, but you can drop any questions or comments into the question and answer box, and we would welcome your interactions during the webinar. We'll make some notes of any questions that come up and comments and come back to them during the Q&A session after the presentations. If you have any trouble with the tech side of things, please first try and leave the webinar and log back in. Failing that, please call or text us on 0497 037 841 and we'll endeavour to assist. I'm hoping that one of my colleagues will drop that phone number into the chat as well. I'd like to also, while I've got you here, take this opportunity to let you know about an upcoming Introduction to Eye Health webinar that we're hosting on the 24th of May. We're going to put the link to register for that into the chat. This is for people working in community and primary health and gives you a high-level introduction to the 5 main eye conditions that cause vision loss and blindness, people at risk, barriers to services and how to overcome them, and eye health promotion. So click on the link in the chat to go to Eventbrite to sign up. I'm hoping that our facilitator has joined us. If she hasn't, I'm going to continue on hosting. Okay, all right. I will push on. If our facilitator joins us a bit later, I'm hoping that she will host the Q&A session for us. So just a little bit of background about Macular Month. It's an initiative of the Macular Disease Foundation, and the focus of Macular Month has always been on raising awareness of macular disease. The most common macular diseases are age-related macular degeneration and diabetic eye disease, including diabetic retinopathy and diabetic macular edema. Part of the Vision Initiative's remit is to provide information to Victorian community health professionals to support their work with people who are at increased risk of vision loss. We meet this remit in a number of ways, including through presenting webinars like this. To acknowledge Macular Month, we have brought together some expert speakers to guide us through what we need to know as health professionals when working with clients and patients at risk of AMD. We've been joined today by Sabine Ostrowski, National Manager of Healthcare Relations at the Macular Disease Foundation, Joseph Waterman, an optometrist working in with the Australian College of Optometry, and Simone Hibbert, an optometrist working in independent practice. We'll hear from each speaker and then we'll have some time for questions. Towards the end of each session, towards the end of the session, we're going to share a QR code with you that you can use to access a short feedback survey to help us understand how you will use the session, what you've learnt from the session today. Okay, so that's I think that's all the introductory stuff, and I'm going to move on now to introducing Sabine. She's our first speaker, joining us from the Macular Disease Foundation of Australia. She is an experienced optometrist, a graduate of the University of Melbourne, and currently completing her Master of Public Health with the University of New South Wales. Driven by a strong interest and passion for public health, Sabine moved from a career in clinical practice to the not-for-profit sector to drive and improve public awareness of eye health and the causes of preventable blindness. A dedicated and evidence-based clinician and educator, Sabine is excited by the expanding role that MDFA is pursuing into health professional education. Sabine is the chair of Vision 2020 Australia's Prevention and Early Intervention Committee, and she's a member of the Aboriginal and Torres Strait Islander Committee. Sabine is also a member of Optometry Australia, the Australian College of Optometry, and the Panellists Pharmaceuticals Geographic Atrophy Educational Steering Committee. And with that, I will hand over to Sabine. Thank you.
Thank you so much, Che, for that very long introduction. I think I need to edit my bio. Thank you so much for the invitation to speak today. Mac Month is a massive part of our work at Macular Disease Foundation Australia, and I'm very excited to be able to talk to a different kind of audience. Now, hopefully you can see my presenter screen. Everything's good. Maybe Joseph can give me a nod. Yep, excellent. So today I'm going to be talking about age-related macular degeneration, which is quite a mouthful, so I will be referring to it as AMD. And it's really great to be talking with community health workers. And because you all have different ways of referring to your patients, if I use patient or client or resident intermittently, please forgive me. I'm trying to cover everybody who might be here today. So firstly, I wanted to start by bringing to mind how prevalent AMD is. AMD is the leading cause of legal blindness in Australia. And at 50, 1 in 7 of us will already have some sign of AMD. And as we grow older, obviously that will increase. What's also interesting to know about AMD is that 1 in 4 people have not been diagnosed. And we'll talk a little bit more later on why that might be the case. And when you compare AMD with other causes of legal blindness, such as glaucoma, which I'm sure you've heard of, and cataract, you can see that it really does take the majority of that pie. So age-related macular degeneration. The age-related and degeneration bit we get. I certainly know when I look in the mirror in the morning, age is not kind and there's a bit of degeneration. But the macular is where a lot of people get lost. They're not entirely sure. They know it's something to do with the eye, but not entirely sure where in the eye and why that's significant. And so I wanted to do a little whistle-stop tour of the eye structure. Now, for some of you, this will be very easy. And for others, it might be the first time you're seeing an eye. So on the right-hand side, you can see a cross-section of the eye cut through that way. And when you look at something as in front of you, the light from that travels into your eye. And the eye is very much like an old style camera. So the light travels into the eye via the pupil, which is the little hole in the sphincter muscle, which controls the amount of light that's allowed into the eye and helps to focus the light as well. And that's very much like the aperture, of course, in the camera. It then moves through the lens of the eye, which is like a clear window when you're born and over time can become cloudy, which is something called cataract. And the lens helps to focus the light from what you're looking at onto the back of the eye, which is the retina. And the retina is that pink lining which covers the whole of the eye interior. So I'm going to use my laser pointer. So all of this area here, this is retina. So the retina is like the film in the camera. It captures that light that has entered the eye and it then translates it through a process into electrical energy that then is taken to the brain and the visual cortex in the brain. And that's done through the optic nerve. And the macula is this little tiny area here that's circled in green. It's a very, very small part of the eye. It's about 5.5 millimeters wide, but it's integral in 90% of what's processed in the visual cortex at the back of the brain. And the reason the macula is so important is it's responsible for your central vision. So over time, there's some type of dysfunction in AMD, which we're going to delve into a little bit. And what happens is people start to lose that central vision. So when you look at someone's face, or you're trying to read fine print on a medicine bottle, or you're looking at color, those tasks use your macula. And so over time, you start to lose that central vision, but you retain the peripheral vision. So that's essentially AMD in a nutshell. And if you look at the image on the left, that's actually a photo of the retina. So when you go to the optometrist and you have a photo taken of the back of your eye, it's actually a photo of that interior lining. And you can see that here you've got the optic nerve, which you remember was here. And here is the macula, this little area there. Now, we like to talk about the stages of AMD because depending on what stage your client or patient is at in their AMD journey will impact how you can advise them to make the adequate dietary and lifestyle changes and perhaps support them if they're in the treatment phase. So there are 3 stages, and we will touch on them briefly. The first is early AMD, then there's intermediate AMD, and then there's late AMD, which is can be broken into 2 different types, which is atrophic, which is the preferred language, but we sometimes call it dry AMD. So your patients or clients might say to you, yeah, I've got the dry one. And then we have neovascular AMD, which is the wet one. So just going back to the image of the eye from before, so this is where we are. We've taken a little cross-section of the macula and we've blown it up. So here you are looking at the macula under a microscope. So what happens in AMD is that as the light travels into the eye, so remember it's coming from this direction, the photoreceptors, which are the special photosensitive part of the eye, that's like the film in the camera, they capture that light and there's a metabolic process which produces waste. And that's like every other process in the body. Any part of your body where there's cells working, they produce waste. And in a normal, healthy, functioning eye, what happens is these funny looking cells with the funny legs, we call those the retinal pigment epithelial cells, I call them the dump truck cells, because essentially what they do is they transport the waste from these photoreceptor cells from the process of seeing, and they transport that waste into the bloodstream so that it can be taken away. So that's what happens in a normal eye. Unfortunately, in AMD, there's a breakdown in the truck. So the garbage truck is no longer working, and all of this waste product has been developed in the process of normal vision and normal seeing starts to accumulate in a part of the eye where we normally don't see it. And this is called drusen. And so often patients know that they have a bit of drusen, but they don't entirely know where that is. But now you know it's at the macula and it's not normally in this position. And so when you go back to the images that we were looking at before, here was the healthy eye with the healthy macula. You can now see with this one that there is these tiny little yellow dots, and that's the drusen, very faintly visible to the naked eye here, but that's what the optometrist sees when they examine you. Now, at this stage, most people will have no idea that they have AMD. And then over time, they may move into intermediate AMD. And what happens then is that the drusen start to become larger, they may coalesce or join up, and you might see some other changes happening at the macula as well. Now, the happy news is 85% of people won't progress after this. This is where they stop. So they have these small changes at the macula and they're largely unaware, which is a good thing. However, there is the unlucky 15% who then will go on to what we call late stage AMD. And in late AMD, there are, as you'll remember from before, 2 different types. There's one where the photoreceptor cells, remember those ones we were looking at, the long ones, they start to shrivel up and die or atrophy. And so what happens is you're left with these moth-eaten holes in the film of the camera, if you want to think about it that way. So remember, the whole retina is like the film, and here at the macula, you can see these little holes. And so this is quite impactful. People will start to notice that they have different symptoms. However, sometimes even not now, because we have two eyes and the good eye always takes over. So even with late AMD, patients are often unaware that it's as far progressed as it is. And then the last stage of AMD, which is still the late stage, but in the neovascular form, is an interesting form, because what's happened is the eye is trying to repair itself. So it knows that there's something not quite right, and the eye's response is to grow these small little new blood vessels into the retina, which is not normally where we see them. The problem is that these little vessels are leaky, and so what happens is they leak fluid and blood into the macula, and you can see that's pretty devastating. So you can imagine this is the kind of person that will turn up on a Sunday morning in my practice and they'll say, Sabine, it's like someone's taken an ink dropper and dropped some ink into my eye. It's very sudden, extremely scary. But again, I have had a patient who walked around with it for quite a long time because the other eye was doing all the work. And so that's the key reason why often patients are undiagnosed, because if they're not having eye care, not seeing the optometrist regularly, this can still go unnoticed. So what are some of the symptoms that you can perhaps look out for with your clients or your residents or your patients? Well, the first of those is having difficulty discerning fine detail. So this can be a lot of different things, but often what it means is if people normally wear reading glasses, they're wearing the reading glasses, they're clean, they have good light, and they still can't make out that fine detail, then that might be a good moment to say, it might be time for you to go and have an eye test. It may well be cataract, it may well be other types of eye disease, but it's an important one to have followed up with the eye health practitioner. The second symptom is a bit more obvious, and this one is a great one to look out for. So often patients will notice that, particularly in the late AMD, that when they're watching TV, the side of the screen is wobbly. Or they might be in the bathroom and they notice that tiles on the wall are wobbly. I have a patient who came in and she dislikes her council intensely. And today she was particularly peeved because they had apparently painted new lines on the road, but the lines were wonky, which of course was her AMD and not the poor council person. So any type of distortion is a sign that the macula's normal shape has been altered and is a really important sign to not miss. So if anyone says to you, I've noticed a change in my vision, always good to go and see an optometrist. But if it's a wonky, distorted, weird thing, that's an urgent thing you want to send off pretty quickly. And then the last of the symptoms is the dark central loss, which you can see kind of described in that third picture. Now it's a little bit, that's obviously not real life. It can vary between patients or people what they actually see, but essentially what it's trying to demonstrate is that there's a change in that central vision, a bit like someone has a fist on the end of their nose. They can see around it, that's fine, but they can't see that central part. So those are the three key things that perhaps you can look out for. And if you hear that people are presenting with that, that's a good time to refer them on for care. So this is a good little video just to show you how when she looks down and at the carer, she's lost that central vision. But when you look again, you can see the flowers and you can see the gentleman off to the side. So she's retained her peripheral vision. And for most people, they're very lucky because with AMD, because if AMD is all they have, they will never go what they call black blind. They will always retain that peripheral vision and be able to manage. And so another symptom perhaps to think about also is you may have people that you interact with who may not directly look you in the eye. Now there's other reasons that they may not do that, but sometimes it can be that they're scanning. So you might notice that they look at you, but then they look a little bit off center And it's because they're trying to find that good bit of vision using the periphery. So let's talk about risk factors. Risk factors are really important to understand because then you can perhaps help patients and clients to negotiate, well, what can you do given that you're at risk? First, you need to know you're at risk. So the first two strong risk factors for AMD are, of course, age, which we've already talked about, but the other is family history. And family history is really important because we know that if you have somebody in your family with AMD, you have a higher risk of developing AMD. If that person is a first-degree relative, so a parent or a child, then your risk over your lifetime of developing AMD is 50%. So it's significant. So it's really important to understand that. Now, we haven't found the fountain of youth. And as we know at Christmas, we can't necessarily pick our families, but we can do two really important things to manage those two risk factors. The first is make sure you have a comprehensive eye exam at least every year if you're over 65, and more often if you've been advised to. So a comprehensive eye exam is with somebody that you can talk to, can ask questions, who you've seen before. It's good to have a history, and who does the required types of tests, which I know one of the other speakers will be talking about today. The second thing that you can recommend, and this is something that you can access, in fact, your clients or patients can also access this, is Amsler grid. Now, the Amsler grid is a basic little test of the macular integrity, and it's something that you can order from our website and it gets sent to you at no charge. It would be good to have one on you or when you visit people or in your office, because if somebody comes in with very strange, weird symptoms, it's a good little check of the macula. It's done with one eye at a time, and it's important to follow the instructions. And on the MDFA website, you can actually see a small video on how to instruct someone to do the Amsler grid. So the two things together, the comprehensive testing and the Amsler grid in between, are really important. And if you're visiting someone in their home and they have an Amsler grid on the fridge, it's probably worth asking them, when was the last time you actually did that? Because often people hang it on the fridge and then forget to actually do it. And it's really important that they do. Now, the third strongest risk factor for AMD is smoking. And the important thing about smoking is it's the only modifiable risk factor. We know that people who smoke are 3 to 4 times more likely to develop AMD. We know that they're more likely to develop it at a younger age, in fact, 10 years earlier. And we also know that they are more likely to develop the late stage of AMD, the one that really impacts vision. So helping people to quit is a really important reason, if not for their general health, particularly for their eyes and for AMD. And then we come to the next layer of risk factors. So the key ones were age, family history, and smoking. They're the strong risk factors. Then we have another level of risk factors called moderate risk factors. And moderate risk factors, there's 3 of those: a BMI of over 30, somebody who has hypertension or trouble with their blood pressure, and people who have cardiovascular disease. When people have this moderate risk factor, there are healthy lifestyle changes that you can recommend to help modify that risk. And so at the foundation, we do a lot of work about the importance of exercise and sun protection. Protection from UV obviously is important, not just for the macula, but also for cataract, but also about eating macula-friendly food. So all of the information that we provide to practitioners in the community are evidence-based recommendations. So the evidence from data that's been well proven. The first recommendation to a macular health friendly diet is to make sure that people are eating 1 serve of green leafy vegetables every day. And so we mean kale, silver beet, those types of really good cruciferous type vegetables. I missed one: kale, silver beet, and spinach. Spinach is the obvious one. They're very high in something called lutein, which is an antioxidant, which is found in really high concentrations at the macula. The second recommendation is that people eat 2 to 3 serves of oily fish a week. And by that we mean salmon, mackerel, sardines, that type of fish for the omega-3, a mixture of nuts 2 to 3 times a week, which includes the magnesium and selenium that's important for a healthy eye, as well as the Mediterranean diet, and making sure that you're eating the rainbow of the fruit and vegetable. So I've come up with a little mnemonic for community health workers and the types of things, 5 tips for you to think about when it comes to the eyes, particularly AMD and your clients or patients. And it's based on this little guy who most of you will know because I think they've had a revival. It's a Smurf. But as you can tell, this Smurf wears glasses, so he's not spelt quite right. So there are 5 things that you can do to really make sure that your patients or clients are well looked after. The first is to make sure that you discuss smoking and get them to quit. We know that's good for a whole host of reasons. We want them to monitor with the Amsler grid, which you know you can access through our website. You want to make sure they have regular eye tests. You want to make sure that if you notice any weird symptoms being reported or concerns, or they're being diagnosed and they need support or information, that they are referred to the optometrist or to the MDFA. And finally, that you think about encouraging them, which is of course good for all aspects of their health, but particularly for the macula, to eat that really balanced diet. Because we know that vision loss has a ripple effect. People who experience vision loss are twice as likely to slip and fall, and we know that that can lead to increased risks of being admitted to nursing care. We know that people with vision loss are 3 times more likely to develop depression and twice as likely to use health services. And so that's why they need support. So at the MDFA, you can call the National Helpline, or you can refer the patient through our website, and they'll talk to our staff at no cost who are trained. They can access supports and services, which range from resources, booklets, the Amsler grid. They can attend webinars online to find out more about their own health and improve their health literacy. And one of the biggest parts of our work is peer support. In the last few years, we've developed 3 types of peer support: face-to-face, where people can share their lived experience, but also by phone and digitally for people who are remote and find it difficult to get out. And of course, we link them to the low vision services as they move into the late stages of AMD and their vision starts to become impacted, as well as talk them through the different government services that they might need at this stage of life and are always difficult to understand. And the toll-free helpline is as displayed there, but you can also refer people directly via the website. So I'm now going to hand back to either Che or Ashley